following these two talks, we will have a panel discussion, and we have invited Professor Pablo Avanzas, who is the secretary of ISCP, to join us for the discussions. He is consultant in interventional cardiology at the University Hospital of Asturias in Oviedo, Spain. He's also professor of medicine at the University of Oviedo in Spain. And as I said before, Professor Avanzas will join us during the panel discussion. And thank you very much, Professor Avanzas, for joining us in the panel. I would like to start, asking Professor Dan about the problem of bleeding in COVID-19. Is it infection related? Are there other mechanisms? Could you please, George, speculate on this?
Thank you so much. Indeed, it's amazing that, in fact, there are similar rates of thrombosis and bleeding in the COVID-19. And the rough percentage is below 5% for patients with COVID-19 infection. And this is regarding the bleeding because, in fact, there is a very low rate for disseminated intravascular coagulopathy. So it is not this the mechanism for the bleeding in COVID. In a very large retrospective analysis made by Samkari and published 1 month ago on data from 400 hospitals, the overall bleeding rate was 4.8 with 7.6% in the intensive care unit, and the figures are 2.3 respectively 5.6% for severe bleeding. Dedimer increase and thrombocytopenia are predictors for bleeding, and this subject is really challenging because there is pressure for intensified anticoagulation in COVID patient, and this measure could be not really beneficial until we have a clear explanation for the bleeding in COVID patients.
Do you envisage that the use of anticoagulants and antiplatelets, as you have actually mentioned in the talk, will that be a problem, or you think we will see less of a problem in terms of bleeding?
The problem is that the free application of recommendations without studies for full doses or enhanced doses of anticoagulation could be not beneficial for patients with COVID-19 infection. And in fact, we need to wait each case for administering anticoagulant or antiplatelet therapy.
Thank you very much. Professor Hasegawa, would you like to add to Professor Dan's comments?
Yes, I have no special comment, but just I'd like to add a comment about the indication of the anticoagulation, the ethnic differences. Actually, in generally speaking, the frequency of thrombus is much more in Caucasian and less in Asian. So in Japanese guideline, they say that they do not recommend for all hospitalized COVID-19 patients anticoagulation. Just only a patient with elevated D-dimer level, we should consider the anticoagulation. So the recommendation is not so strong as in the US or EU. So that is just a point of discussion about the ethnic difference. We do not have so much evidence at present.
Yeah, you made a very important point, both of you. Individual patient problem need to be sorted out based on that individual patient, and we need more data before we can actually move on to recommendations that will be applicable to more than the single patient we're actually assisting at the time. Allow me to reinforce the message regarding mechanisms of acute coronary syndrome in COVID-19. And I would like to ask Dr. Avanzas from his perspective as an interventionist, what are the mechanisms that clinicians should be looking at?
Thank you very much, Professor Kaski, and also the organization for the opportunity to join this fantastic webinar. Congratulations to Professors Dan and Hasegawa for the excellent lectures. Regarding this point, I think it's very interesting because we are learning of data is being published, and I think we have three different mechanisms in the acute coronary syndrome establishment. One is obvious is plaque rupture, the second is coronary spasm, and the third maybe the presence of microthrombi and the issue of the vasculitis in the coronary tree. More interesting, I think, are the triggers of the acute coronary syndromes that we have. On one hand, all the systemic inflammation and also the cytokine storm, but I think it's quite interesting the other trigger that's maybe the direct damage of the virus to the coronary tree, as we can see in one paper by Stefanini, that he analyzed in the Lombardy region all the ST elevation myocardial infarction patients, and the authors of this paper see that in a high percentage of cases, the patients do not have any other manifestation of the COVID, and is the first clinical presentation of the COVID-19 disease. So I think this is very interesting.
Thank you very much. Professor Hasegawa, would you like to add to Professor Avanzas' comments?
Thank you very much. Mostly the possibility has been described by Professor Pablo, but I'd just like to stress the importance of differential diagnosis, because there is the possibility of myocardial infarction due to the obstruction of the epicardial coronary artery, and also the possibility of vasospasm, and also the possibility of small coronary artery disease. And it has been also shown that Takotsubo or cardiomyopathy also occurs in COVID-19. So we need the differential diagnosis if we see the patient with acute coronary syndrome. Is it really due to the obstruction of the epicardial coronary artery, which will be the most important in the clinical point?
Thank you very much. Professor Dan, Dr. Avanzas actually alluded to sort of mechanisms that you presented in your talk. Would you like to elaborate on the importance of microthrombi in this context?
Thank you so much. I would like to emphasize on 4 points on the issue. First, that compared to studies in the last 7 months on pulmonary pathology, there are fewer studies dealing with myocardial pathology. The second important point, which was also presented by Koji in his excellent talk, is that the angiotensin-converting enzyme 2 receptor has a very low expression in the heart, and at the present there is a debate regarding the virus concentration in the myocardium and the direct participation of the virus to the acute coronary syndrome. A very recent paper published this week demonstrated that even in the very florid patients with severe COVID disease, there is an increased concentration of virus, but not of the immune cells. This is a little bit confusing because in the international experience, it was demonstrated that many patients have no really culprit arteries, but the microthrombi. And in our own experience in the hospital, we have 5 cases of ST elevation myocardial infarction with no culprit artery, but only microthrombi in smaller arteries. And the fourth point, which is after me very important, several statistics demonstrated that MINOCA, so myocardial infarction without coronary artery disease, is very prominent in COVID disease. So there is a desperate need for a better understanding of the pathogenesis of COVID-associated myocardial infarction and acute coronary syndrome.
Thank you very much. I would like to move very briefly, if I may, very, very briefly. There are papers suggesting that in addition to the non-specific inflammatory mechanisms that lead to thrombosis in patients with COVID, there may be some more specific mechanisms associated to SARS-CoV-2 infection, which contributes to the prothrombotic state. Professor Hasegawa, would you like to very briefly tell us something about this?
Yes, yes. And well, there is a report to compare the frequency of pulmonary artery thrombus demonstrated by contrast-enhanced CT between influenza and COVID-19. They showed apparently the frequency of pulmonary artery thrombus is much more in COVID-19 compared with influenza. So apparently there is a specific mechanism in COVID-19 in addition to the general inflammatory mechanism. And also in COVID-19, even though we perform the anticoagulation, pulmonary artery thrombus frequently occurs. So we need to be very careful for that event.
Thank you very much. Thank you very much indeed. There is an important practical question that I would like to ask to Dr. Avanzas. And this is in relation to what intervention, how we manage patients with STEMI and COVID-19. Are we going to take these patients to the cath lab and do a primary PCI, or can we actually afford doing fibrinolysis in these individuals?
Thank you. Thank you. I think this is a very, very important point because as Professor Dan pointed out, in this setting, even more or less half of the patients will not have occlusion of a culprit vessel. So this is the point. But with the ST elevation, there are different management strategies along the different societies. I mean, you know that European and American guidelines endorse the primary PCI over the lytics, but some Asian, for example, the Taiwan Society of Cardiology endorsed lytics over PCI. So it's not clear because of the risk, obviously, of infection of the personnel. I think primary PCI, under my point of view, is important because if you do lytics, some patients will not have lesions, so there's a risk of bleeding. On the other hand, if the vessel is occluded, just 50–60% of the patients will get a patency of the vessel. So the other 50% will go to rescue PCI or to elective angio in the following days. So we have to balance. Also, with the lytics, the point of bleeding, we don't know what will happen with the lytics and the prothrombotic stage of these patients. Another point is stay in the coronary care unit. Patients with lytics maybe will be more, the length of stay will be longer compared to the management in the cath lab. So this is also important in cases we have to, the resources, we have to choose which patients will go to these units. And I think the last point should be the paper published in New England Journal, in which you can see that patients with ST elevation that do not have lesions, the MINOCA, the outcome is really bad. It's really bad. On the other hand, those patients that have occlusion of the artery and go PCI gets at least better outcome. So with this data and the risk of infection of the staff, we have to manage.
So basically, it seems difficult at the moment actually to give a general recommendation, but is there any specific patient that you see and you would say, well, there is no doubt that I'm going to go for primary PCI on this patient, and then the other extreme, this patient to me is fibrinolysis and without discussion, or it is impossible to make that distinction?
Some reports say that, you know, that the COVID-19 patients, the clinical profile of the patient with acute coronary syndrome is more severe, and sometimes even you have to intubate very, very quickly, very early. So that's the point. These patients are very dangerous for the medical staff in the cath lab. So nothing is clear, but at least in our center we do PCI to all patients, but it's very difficult. I think that's why different.
So
different
PPI
strategies.
is very important in this.
But
case.
I think if the ST elevation is clear, no doubt, I think you should go for an angio, yeah. Because also the prognosis is different if you get coronary arteries without lesions or you get the occluded lesions.
Coronary microvascular dysfunction. Yeah, thank you. Professor Hasegawa, would you like to?
Yes, this is also, I agree with that. This is a very important question, but difficult question to make a conclusive answer. But I think the most important is a differential diagnosis. As described earlier, the non-coronary myocardial injury is so frequent in COVID-19. First, we would like to know whether the myocardial injury is due to the obstruction of the coronary artery or just myocarditis or small coronary artery disease. We need a differential diagnosis. So therefore, that fibrinolysis from the first is somewhat dangerous choice. I think we need some kind of confirmation of the obstruction of the coronary artery by coronary angiogram. So the catheterization with the first choice. And I think there is a possibility that coronary CT is also one of the options. That the Australian Society say that coronary CT will be also useful to make a differential diagnosis.
Thank you very much for this comment. And you mentioned differential diagnosis. You mentioned myocardial injury. Can I ask you, what is the reason why we see cardiac troponin being so elevated in many of the COVID-19 patients?
Yes, there are so many possible mechanisms. I describe 5 possibilities in my lecture. But if I was asked what is the main mechanism, I would say just the systemic factor will be the most important. The inflammation, so-called cytokine storm, will affect the heart, and inflammation occurs in the heart. And also the low blood pressure and hypoxia will affect the heart. And these 2 factors, systemic factor, will be the main mechanism. But there is also evidence that the virus exists in the heart, and also even 2 months later after the diagnosis of COVID-19, there were abnormal cardiac MRI findings. So there will be also a cardiac specific mechanism that led to the elevation of the cardiac troponin level.
Thank you very much. You alluded to these mechanisms in the lecture, and I saw Professor Avanzas was nodding, and I wonder whether you would like to expand on this, Pablo, or.
I think it has been perfectly exposed by Koji in the presentation, and also now the main mechanisms are clear as described. Yeah.
Thank you, George. Would you like to comment on this point?
Nothing much to complete what already Koji and Pablo said. I only would like to underline 2 myths. The first myth I encountered in my practice during the COVID period is that troponin is not from the heart. On the contrary, troponin is always from the heart. The second myth is that always troponin means myocardial infarction. This was the second myth. I had a long struggle with my colleagues from the infectious disease to demonstrate that not always increase in troponin is myocardial infarction, but could represent injury and not myocardial infarction. And of course, there are, as Professor Hasegawa said, there are many mechanisms for increased troponin and many mechanisms which are not really known at this moment. But the practitioner should be aware of the two possibilities of the myocardial injury, which is not myocardial infarction, and also on the typical increase and decrease of troponin, which signify myocardial infarction. What is very known is that despite the mechanism, the increased troponin is an excellent marker for bad prognosis, bad outcome in patients with COVID. In our experience, patient with high level of troponin had the worst prognosis among the patients with severe COVID disease. Maybe some of them are very delayed because in this period, it was happening in the beginning of the period, the catheterization laboratories were less accessible to the patients, and there was a delay in the presentation of patients with acute coronary syndrome. But despite all of this, increased troponin is an excellent marker for a very bad outcome.
Thank you very much, Professor Dan. And on this note, I would like to thank you all for having given us such a great insight into the cardiac issues of COVID-19 with your talks, and thank you very much to Professor Avanzas for joining us in the panel discussion. Thank you very much to ISCP for endorsing this educational activity, and of course to Professor Hasegawa for initiating this excellent educational activity. Thank you very much. Thank you very much for watching.
Thank you.